Hello there, guys. This is Dr. Mintz. I know we're going through the bowel segment of the course, and you're probably thinking in terms of anatomy or barium studies, but I wanted to embark on cross-sectional imaging because that is a lot of what we will be doing. It's important that you understand cross-sectional imaging, and believe me, you will by the time you finish the program. And I think we'll see many cases, and you'll get very comfortable with the basics of cross-sectional imaging. And I think it's important for credibility with radiologists and other medical professionals that you are conversant at least with the basic anatomy on cross-sectional images, and that you're able to recognize abnormalities. So the point that I have made for several years now is that what I would like to see you all be able to do is to look at cross-sectional images, identify an abnormality, and describe what anatomy is involved with that abnormality. Now, it seems kind of simple, but it's really not, and I think it's an important skill set for you as a radiologist assistant. I think we at first thought you need to learn more differential diagnosis and description of various etiologies which could account for a patient's problems. But I think a lot can be said for being able to identify an abnormality, describe the anatomy affected by the abnormality, and then maybe come up with one or two likely diagnoses. So you'll hear that again and again, and it's the way I see this information, a large part of the program, being relevant to your professional future. That said, let's take a look at this CT abdomen and pelvis. And as is often the case, I just got home from a night of call last night at Wake Medical Center covering the emergency department. And I see many interesting cases, and I've collected quite a few. This is not that uncommon. It's a good case. But I'd like you, as I do this, to just look and take a look and see if you see an abnormality. And remember, once you see the abnormality, you would like to describe what anatomy is involved with that abnormality. So here we are on the coronal plane. Coronal. Okay. It's not that obvious if you're not used to looking at cross-sectional imaging. I can tell you that the patient has right upper quadrant pain and fever. Here are sagittal images. So there we're coming through the liver. And there's the gallbladder fossa right there. The gallbladder looks kind of contracted. Maybe you see something there. Now we're over on the left side of the abdomen. Look right around here. And now we're moving toward the right. And what do we have here? Let's go back to the axial images. We're in the liver here, spleen, and as we go down, we're looking for a bowel abnormality, let me say that. And right here, does that catch your eye? here you have bowel. Some has air, some has oral contrast in it, some has both. And if I move up and down in this plane, look right around here, and do you see that that distinguishes itself from the surrounding structures? Well, that's good if you see that, because I think just seeing an abnormality is critical. Being able to describe it and what anatomy is affected is the next step. And really, those are the two big steps. Third step, differential diagnosis. Really, that is the realm of the radiologist, and the more you know of it, the better. You should have an idea of one or two likely diagnoses, but identifying an abnormality and describing it, I think, is a useful skill set for radiologist assistant to have. Okay, so here you see something abnormal maybe. Here you have bowel that has oral contrast in it, and you see these little valvuli conniventes. In the small bowel, in the colon, you have these haustral folds. You come up the right colon here. So you come up the right colon, and right under the liver, medial to the liver, is the hepatic flexure. So here what you have is oral contrast and air in the right colon and entering the hepatic flexure, and then this loop of bowel let me see if I can center that. This is a little difficult here. Maybe I made it a little too big. Alright, so there. So this is the abnormality, and here is proximal hepatic flexure, and you can see it transition here into this low attenuation structure that actually goes right up to the gallbladder, but the gallbladder is contracted. Here's the gallbladder, so it's just incidentally abutting a portion of the gallbladder. So if we follow it from here over this way, now you see something. Now you see this heterogeneous and somewhat ill-defined area, and these are important terms, important vocabulary words for description of cross-sectional images. So it's a little indistinct here. I think you can see that. Oh, let's see, is this where, how do I go around? Okay, so I can move it that way, center it where I want, and okay. So now as we go through it, you see there is this structure here, and it's not nice and neat, and that's very often the case with cross-sectional images, and especially bowel abnormalities. So now you see here it is proximal hepatic flexure, distal hepatic flexure, and then at about this point it transitions into this thickened, ill-defined structure that has this bullseye, or whatever it is, this white spot, and this is stomach, so don't, even this is where you have to become a little bit more comfortable with cross-sectional imaging and realize, well, this sure looks like it continues over here, but this is normal thickness stomach wall here, and this is stomach there too. But if you follow this, this is the proximal transverse colon here that has this little white dot, which is some of the oral contrast entering a little defect there, and then it comes over this way, and it's hard to follow all the way across on the axial images. Okay, so that is the axial series, and now if we go to the coronal series, I think you'll see a little more clearly what we are dealing with here. There's the liver. Now here we go. Here we go. So now you can see the stomach, and you have this thickened segment of bowel that is the proximal transverse colon. And more proximally, it is the distal hepatic flexure. So it goes from the distal hepatic flexure, and it's not a very clear demarcation between those. It goes from distal hepatic flexure into the proximal transverse colon, and that's what we're seeing here, transverse colon. Okay, so the findings. Description that I would make is there is thickening of the bowel wall involving X centimeters of the proximal transverse colon. Let's see, what are we getting? We're getting about 7 or 8 centimeters there. So there's mucosal thickening of low attenuation consistent with edema. The lumen of the colon at this point appears effaced. The lumen would be right in here, along there, and it's just effaced, meaning closed by virtue of the surrounding walls kind of closing in on it. This is where the colon lumen should be. So there's edema, probably related to some type of inflammation, and we have this little pocket of contrast, and that's oral contrast. How can we put those together? This, by the way, is, as is often the case with this disease, usually quite centrally positioned relative to the abnormality. So it has probably 4 centimeters this way and 4 centimeters that way or so. So, what would you think? It's kind of peripherally located, so you have collection of oral contrast that probably extends maybe farther than the margin of the colon right here. You see how the colon has this margin here and then it bumps into that? So it's actually extending a little bit beyond what would be the confines of the colon wall here, and you have quite a bit of edema there, and the colon mucosa is all quite edematous there. And then here you can see it kind of transitioning to a more normal distal transverse colon. So what this is a diverticulum, a colonic diverticulum. And what has happened is that this diverticulum became infected because it does not have a good rate of turnover of its content, and so when you have things sitting still inside the body, fluid particularly, that is not getting turned over or moved, it can easily become infected. So here you have an infected diverticulum. This is diverticulitis. It produces thickening of the bowel wall, and when severe enough, produces edema of the adjacent soft tissues. So that's what we're seeing here. This stranding right here is different than what we're seeing next to the bowel here. So even though this bowel wall is a little thick and it's a little thick over here, it's thick here too. It has a pretty sharp margin, but right here you see you have that pericolonic stranding, that edema, because this is where the diverticulum is, and this is where the most inflammation is located, and that's right near this diverticulum. So that's why you get mucosal edema involving a long segment of proximal transverse colon with pericolonic stranding adjacent to this small collection of oral contrast, which appears to be in or slightly outside the confines of the colon. So this is a classic diverticulitis. Not the most common location. Left colon, especially distal left colon and sigmoid colon, are far and away more common, but still you can get it anywhere in the colon. So this is diverticulitis. See, the little gallbladder here is kind of squished by this process, but it's also contracted. So this is diverticulitis. And the other thing you want to look for is an abscess. So here it's inflamed, you have a collection of contrast, but you don't really see a defined fluid collection with a wall that would be an abscess. And that can be difficult. That's why we give oral contrast on CT, because this loop of small bowel, if it didn't have oral contrast in it, could look very much like an abscess. It can have fluid and debris and little pockets of air. So oral contrast is vital to define what is bowel, so that abnormal bowel like this becomes far more conspicuous, and things that are of abnormal soft tissue, masses, lymph nodes, and fluid-containing structures that are not bowel, they all become more clearly identifiable. So this is diverticulitis of the proximal transverse colon. Okay, and other little incidentals here. This liver really looks big, especially disproportionate enlargement. This is all left lobe, and then this would be right lobe right here. So the left lobe is bigger than the right lobe, or at least as big. And that's what happens in cirrhosis. The liver overall gets small, and sometimes the left lobe gets enlarged. Certainly it becomes enlarged relative to the right lobe in many cases. Okay, and I'll go through a little bit of anatomy. Why? Because I loves my anatomy, and this is some good anatomy. Cross-sectional anatomy, when you understand this, you really understand the anatomy as a whole. So their stomach, as I pointed out, what would be this venous structure coming into the liver a little bit obliquely, and once it gets into the liver, it branches. This is the portal vein. So the portal vein is venous return from the bowel. And so if you follow this back, you'll see that it receives blood return from the mesentery, and the mesentery is all of these supportive structures here, which contain vessels that take blood to and from the bowel. But as it returns from the bowel, unlike the blood that returns from your leg or your arm or your head, the blood that returns from the bowel, the venous return, has to go through the liver first. And that's what the portal venous system provides, is that route to the liver. Now if you follow this portal vein here, and you follow it off this way, you'll see it goes toward the splenic hilum. Always, always, right smack dab in the middle of the splenic hilum. Now that's not true for very many other types of anatomy, but that's because it's the splenic vein. And the splenic vein courses over to the right, and somewhere along here it's being joined by the mesenteric veins, including the superior mesenteric. Okay, here we go. This is the superior mesenteric vein here, and this is the inferior mesenteric vein. These are not as dense as this because of the timing of the contrast bolus, and more has gotten back into this vein, the portal vein, as opposed to the left and right main, or the superior and inferior mesenteric veins, which don't have as much contrast because there was a longer route that had to be taken by the contrast to get to the bowel and then come back here. Anyway, this is portal venous return. It's coming from the bowel. This is portal venous return, and between superior mesenteric vein, inferior mesenteric vein, and splenic vein, here we have this portal venous return, as it's called, going into the liver. So there's blood flow going into the liver from the portal vein, and there's also blood flow going into the liver from the hepatic artery, which is probably what that little white dot there is. Don't feel like this is something you've got to write down or focus on intently. My goal is to have you hear these things and see them repeatedly, many times, and these structures will become like old friends to you. I think. I'm pretty sure. Okay, and you see the kidneys here, and then just for some big structures. I know a lot of you are very comfortable with some aspects of cross-sectional imaging already. Here is the aorta, right and left renal artery, and here is the proximal branch off the aorta, which is the celiac axis right here. The celiac axis gives off 3 branches, which you will know. And this is the superior mesenteric artery. And if we follow that forward, we see that it goes anteriorly and then it dives down like this. And so this is how arterial flow gets to the bowel. And I think that's more than enough, literally. So I'm going to cut off here, but feel free to email me with any questions. You can watch this multiple times, whenever you want, of course. But at this point, don't feel like, oh, I didn't get this, I didn't get that. You'll get it. You'll hear these things many times.